Thank you, Dr. Bhagyesh sir. Evidence suggests that antibiotics dosing in acute kidney injury does not achieve pharmacodynamic goals, and there is continuously increase in mortality due to infection. Clinicians should be more aggressive in antibiotic dosing, but concerns of associated toxicity are also there. Solution may be give enough dosing but not too much. Let us know what our next speaker, Dr. Subba Reddy, has to convey in her talk on antibiotics dosing in acute kidney injury. What we know and how do we implement it? Sir is senior consultant and head critical care medicine. He is affiliated to Apollo Health City, ISCCM chairman, Hyderabad branch. He is medical director, Apocos Rehabilitation, and chairman, IAPEN, Hyderabad branch. His area of expertise is neurocritical care, ECMO, advanced mechanical ventilation, and renal critical care. Sir, please.
Yeah. Good morning. At the outset, let me thank Gujarat Criticon 2022 organizing team for giving me this opportunity. I'll be talking about renal dosing of antibiotics. So we think it is simple. It is not that simple. When you're doing rounds in the ICU, the consultant will tell the resident do adjust the antibiotics according to the renal creatinine clearance, and then the resident will be struggling, and then finally they will try to call the ID consultant. Sometimes the ID consultant will come. So they are also not at the bedside. So they come in the morning and again next day they will come. So it is a dynamic thing, and then you need to change unless you know good pharmacokinetics and pharmacodynamics of that drug. So it is not possible. If you understand pathophysiology of acute kidney injury, sepsis and all, you cannot do this dosing properly. So it is important to know, and very difficult topic. So I'll try to make it simple. And if you have any questions, you can ask me at the end. So acute kidney injury is very common in intensive care unit, and then mortality associated with acute kidney injury is also very high. And then the patients, if they are requiring renal replacement therapy with acute kidney injury, again the mortality go very high. So inappropriate dosing is very common with acute kidney injury. In one study they found in 40% of the patients there was underdosing of antibiotics when the patient is in acute kidney injury. So inappropriate dosing, mostly underdosing, and sometimes overdosing and leading to toxicities is very common in the ICU. And therapeutic, you may be asking me, we have therapeutic drug monitoring. We can look at the drug levels and then we can adjust. But the limitations of therapeutic drug monitoring, it is not possible to monitor the drug levels, plasma levels of the drugs in for most of the antibiotics. And then it is not available in many places. And turnaround time, if you send how much time you will take to get the report. And then we don't have point of care therapeutic drug monitoring devices, so it is time taking, so we cannot depend on therapeutic drug monitoring. So we need to understand pharmacokinetics and pharmacodynamic parameters, and then we need to appropriately select the dose. It is not enough if you give appropriate antibiotic and then if you don't select the appropriate dose. So if you go back to the basics, pharmacokinetics. What is pharmacokinetics? It is about the drug concentration. What does the body do to the drug? So we know this mnemonic from during pharmacology times we are learning this. Absorption, distribution, how the drug is distributed, how the drug is metabolized, how the drug is excreted. So this is about the pharmacokinetics, and then this decides the concentration. And pharmacodynamics, what the drug is doing to the body. And then this is the if you look at the antibiotics, it is antimicrobial activity, that is the effect, desirable effect, and then toxicity and side effects are the undesirable effects. So what are the factors which affect pharmacokinetic and pharmacodynamic changes in patients with acute kidney injury on renal replacement therapy? We have patient-related factors, and then we have drug-related factors. The most important thing is the solubility, whether the antibiotic is hydrophilic or lipophilic, and then the volume of distribution. And then we have RRT-related issues like what type of RRT we are using. Are you using CVVHF, or you are using CVVHD, or what is the type of filter we are using, and what is the dose of dialysis? All these things will determine your antibiotic dose. So objective of my talk will be, so to make you understand about the PKPD parameters in acute kidney injury, and then how to calculate the GFR, how to calculate the, like if there is any renal dysfunction, how to calculate the GFR, what formulas we'll be using, and how we'll be adjusting these antibiotics. So the pharmacokinetic consideration depends upon the volume of distribution, and then the plasma protein binding, clearance, and then half-life. So what is volume of distribution? So this is amount of the drug in the body divided by the plasma drug concentration. It depends on plasma protein binding, tissue binding, and local like is total body water determines the volume of distribution. So what are the factors which affect volume of distribution in sepsis leading to acute kidney injury? So there are changes in extracellular volume, blood loss, and then the fluid shifts, and then you do fluid resuscitation in septic patient. So all these things will change the volume of distribution for the given patient, and these changes are dynamic. And in what phase your patient is in sepsis, it is not easy to understand. Initial flow phase, where the cardiac output is increased, and then there is increased cardiac output, and then you are giving resuscitation fluid, and you are using vasopressors. So we'll come to augmented renal clearance later. There is increased clearance, and then there is increased volume of distribution, and then there is a decrease in albumin. This hypoalbuminemia again will lead to the severe hypoalbuminemia, leading to increase in volume of distribution and then the clearance. So as I told, in sepsis there are different stages. There is leaky capillaries, increasing the volume of distribution, altered protein binding, and then increased clearance, and then there is augmented renal clearance. Because of this, there is increased clearance, and then all these things will lead to low plasma concentration. And then like you might have seen, like if you look at the antibiogram, there are higher MICs are required, but your plasma concentrations are low, so you are underdosing the antibiotic. So if the patient is on again extracorporeal circuits, there is increased volume of distribution, so you need to select your proper loading dose of antibiotic. But later, if the patient goes into organ dysfunction, end organ dysfunction, there is hepatic dysfunction, renal dysfunction, and then there is a decrease in the plasma clearance, and then there is increase in plasma concentration. So there you will have drug toxicity. So as I told, the clearance is very important to determine the maintenance dose. Volume of distribution is important to know the loading dose, and clearance is defined as volume of plasma from which solute is completely removed per unit time. So this is important to give the proper maintenance dose. So what is this augmented renal clearance? So there is a good review article in Antibiotics Journal in 2020, and then about augmented renal clearance. What is augmented renal clearance? The augmented renal clearance is defined as the estimated GFR if it is more than 130 ml per minute. That can happen in the initial phase of sepsis, burns, trauma, where there is preservance of hyperdynamic circulation. So this augmented renal clearance is seen. But so how to identify this? There are different scoring systems. You can go through that review paper. There is ARC scoring system, or there is architect scoring system. This depends on the age of the patient. In trauma patients, they use this scoring system, and then we can determine the augmented renal clearance. So this phenomenon results in underdosing of antibiotics if there is augmented renal clearance. So this happens because of increased intravenous fluids, and then increased organ blood flow, and younger people, the renal preservation is there, the renal reserve is good, and then there is increased GFR, and then the increased clearance, and then this will lead to underdosing of antibiotics. So you need to have strategies for antibiotic dosing when there is augmented renal clearance. What strategies you are going to have? So use maximum approved dosing regime, administered doses in continuous or prolonged infusions if you are giving beta-lactam, and then therapeutic drug monitoring is important when there is augmented renal clearance, and then switch to alternative agent which is not largely renally eliminated. So these are the strategies which will help you if there is augmented renal clearance. The plasma protein binding, and then if there is high plasma protein binding, then it is poorly cleared by CRRT. And you know, all the acidic drugs are like they bind to the albumin. And then pharmacokinetic changes, what we see in acute kidney injury, are there is a large volume of distribution, and then prolonged drug half-life. In return, it causes reduced drug metabolism and reduced drug clearance, and then there is increased free drug concentrations because of the pharmacokinetic changes we see in acute kidney injury. So the RRT, the renal replacement therapy, and AKI, CKD, RRT ultimately lead to changes in the loading dose and maintenance doses. You need to properly select, change the doses according to this. And then we know there are two types of antibiotics. One is hydrophilic antibiotics, and then the other one is lipophilic antibiotics. And hydrophilic antibiotics, there is increased volume of distribution in sepsis, whereas for lipophilic antibiotics, it won't change. If the patient is obese, and then there will be a large volume of distribution for a lipophilic antibiotic. But if you are giving hydrophilic antibiotic, like most of the time, we whatever antibiotics we use in intensive care unit, they are beta-lactams or vancomycin. All these are hydrophilic antibiotics, and then you need to give proper loading dose. So these are the hydrophilic antibiotics: aminoglycosides, beta-lactams, carbapenems, glycopeptides. And then during sepsis, there is increased volume of distribution. You need to give increased loading dose, and then you need to modify even your maintenance doses. So meropenem is not nephrotoxic, but you need to adjust the dose whenever there is, you need to give, if there is augmented renal clearance, you need to give 2 grams bolus and then 2 grams IV 8th hourly. So you need to adjust all your beta-lactams, but if you are selecting lipophilic, then you need not change the loading dose. And then antibiotics are again classified into time dependent, concentration dependent, and the both area under the curve by MIC. So all the carbapenems and most of your hydrophilic antibiotics are time dependent. Again, if the patient is on continuous renal replacement therapy, CRRT, you need to give loading dose, and then you need to increase your maintenance dose. Or if it is concentration dependent, you need to give the loading dose, and maintenance dose is not that important. So as I told, when you give a drug, the drug will be distributed based on the volume of distribution, and then based on the clearance, it will get cleared. So the volume of distribution and clearance, these are the key parameters to change the drug concentration in the body. So for loading dose, you need to remember the volume of distribution. For depending on the clearance, you need to select your, titrate your maintenance dose. So when it comes to continuous renal replacement therapy, when the patient is sick and hypotension on vasopressors, we'll be choosing CRRT. So if the patient is on CRRT, you need to select based on the patient-related factors, what we have seen, and then the antimicrobial related factors we have seen. And what are the RRT related factors? So it depends on what kind of modality you are using. So if you are using like high flex membranes, even larger molecules like vancomycin is also removed, and then the membrane. What membrane is there in the filter? This membrane causes adsorption of the antibiotics, and then you need to increase the dose of these antibiotics. Again, what modality you are doing? CRRT, there are different modalities. CVV-HDF. So CVV-HDF, it removes most of the antibiotics, even large molecule antibiotics. You need to increase the dose. And then next one is CVVH, and then the next one is CVVHD. CVVHD, the antibiotic loss is not that much, and there is something called sieving coefficient. This predicts the likelihood of drug removal by dialysis. Sieving coefficient is nothing but the ratio of drug concentration in the ultrafiltrate divided by the drug concentration in the plasma. Depending on the sieving coefficient, you will know which drug is removed in the effluent. So, and during hemodialysis, small molecules are removed, and hemofiltration, even large molecules like vancomycin is removed if you are going for hemofiltration. So if you look at the CRRT emission, this is the effluent bag, In the effluent bag is nothing but urine. So whatever antibiotics you are giving, they are excreted into the effluent bag, and then they are wasted, and we need to properly dose. You need to increase. If you are giving colistin, you will be giving 9 million units as bolus, as initial loading dose, and then you will be giving 4.5 million units TID. So when the patient is on CRRT, the colistin is most commonly used antibiotic when we have gram-negative drug-resistant bacteria. So the first step is to calculate the creatinine clearance, whatever formula you use. Most of the time, we use Cockcroft-Gault formula, and sometimes in most of the labs they're using MDRD formula, and then they're giving eGFR, or we can use CKD EPI formula, and then we can calculate the eGFR or creatinine clearance, and then identify the type of antibiotic, identify the type of infection, and then you need to select your antibiotic. So there are advantages and disadvantages of all these equations. If you are using the most commonly the Cockcroft-Gault formula, it overestimates your creatinine clearance, and then if you are using MDRD, then it underestimates. So in some places they use CKD EPI formula, but we have disadvantages. All these are dependent on creatinine. Creatinine is not, it will not tell you the dynamic changes what happening in the intensive care unit. So based on the creatinine clearance, you select the antibiotic dosing, and then consider the toxicity of the antibiotic, consider the clinical condition like serum creatinine, how it is changing, and then how is the patient stability of the patient, and then where is the infection, is it meningitis, and then you need to give higher doses, or is it pneumonia, and what is the target organism, and then you need to select your appropriate antibiotic. So this table you will commonly find how to dose your antibiotics during renal replacement therapy, and the most commonly used colistin we should know, but the PK/PD parameters are fully understood about the colistin. So if the patient is on CRRT, give a loading dose of 9 million units, and then you give 4.5 million units 3 times a day. So this is how you need to dose your colistin when the patient is on IHD, SLED, and CRRT. If you remember 30 to 50 creatinine clearance, what dose colistin you give? So that is around 8 million units in a day, and then most of the time for SLED and IHD, that is enough. So this is the table. And then how to dose vancomycin? Again, when you are treating gram-positive infections, MRSA, so we are using vancomycin. So we have to give a loading dose of 25 milligrams per kg, and then after your 1 hour before your high flux dialysis, you need to give extra dose 500 to 750 milligrams, and then you have to do therapeutic drug monitoring of vancomycin, and then that is during the third dialysis session. Just before the third dialysis session, you need to send your vancomycin levels, and based on the vancomycin levels, you need to give extra dose of, you have to decide whether to increase vancomycin dose, or whether you have to stop vancomycin, or we have to decrease the vancomycin dose. So beta-lactams, they are time-dependent bactericidal activity, and removal of piperacillin tazobactam during CRRT is very effective. So the loading dose you should not neglect, and then you should give higher doses of beta-lactams, and then you need to give it as an infusion. So to conclude, the basic principles suffice to calculate the dose adjustments, and calculate the GFR with whatever formula you are comfortable, and therapeutic drug monitoring is mandatory for few antibiotics. If you have facility to monitor TDMs, you have to monitor, and expanding the possibility of therapeutic drug monitoring is the only way forward to improve the accuracy of the drug dosing in critically ill patients. So we need further studies for better prediction of doses when the patient is on CRRT or renal replacement therapy. And dose derived from IHD cannot be simply prescribed during CRRT. It is not same. Whatever dose you select in IHD, it is not same when you are using CRRT. So when the CRRT is stopped, again you need to adjust the antibiotic doses. The loading dose stays the same for all antibiotics in CRRT. And if it doesn't require renal dose adjustment, it doesn't require adjustment of CRRT, adjustment for CRRT. So always you remember, if the creatinine clearance, whatever recommendations are there for 30 to 50 ml per minute of creatinine clearance, when the patient is on renal replacement therapy, these doses are most of the time they are enough. So use TDM whenever it is available. Thank you.
Any questions? Thank you, sir, for your detailed talk.